I logged into it from different account. And uh, on behalf of Indian Psychiatry Society Karnataka chapter, I welcome all the faculties of JNMC Belagavi as well as the other faculties from different colleges from the Department of Psychiatry and all the postgraduate students. And also I welcome our secretary as well as the coordinator Dr. Suresh and other people and postgraduate for this IPSKC psychiatry. And I welcome past president of IPS Kelly JNMC Belgavi. So this series has been started since few years because most of the PGs have different type of teaching programs. So to have a commonality, and second one is there may be some cases which have been unique. So let the other postgraduates from different colleges can have their ideas and about the clinical case, the management plan, etc. So with this, I welcome once again everybody and also thank the KLE JNMC people, Department of Psychiatry, for hosting this session. So to Dr. Sorry. And Narayan.
Dr. Narayan.
Hello.
Yeah, we can hear you.
Yes, sir. I again welcome all of you for this fifth case conference under the aegis of Indian Psychiatric Society Karnataka chapter. So, first of all, I would like to thank Dr. Vinayak Koparde, Dr. N.M. Patil sir, and the whole team of KLE Jawaharlal Nehru Medical College for organizing this fifth IPSKC case conference. Thank you, all the participants. Thank you. Over to Dr. Vinayak Koparde.
Thank you. Thank you, Dr. Narayan. Let me take this opportunity to welcome Dr. N.M. Patil, who is the chairperson for today's case conference. Some echo. Yeah. So, Dr. N.M. Patil does not need any introduction because he's a well-known figure in psychiatry of India. He is Professor Emeritus at Jawaharlal Nehru Medical College, Belagavi. He is been awarded with Teacher of Teachers, Best Teacher. He served many positions at various national, state, and zonal levels. The recent being he was president of IPSKC. He knows how to read the pulse of the students, and that's why he is quite liked by students because of his innovative teaching methods, engaging, and more so, he would make students to reflect on what they are teaching and other parts of their life as well. So I welcome Dr. N.M. Patil sir, who has kindly agreed to chair the session, and request him to start the session. You can, we'll just get the slide. Yes. Yes, yes.
You can start. You're audible.
You are visible and audible.
Good afternoon to everyone. This is an innovative exercise from IPSKC started, as Dr. Bijay was telling, a few years back. And we have a successful run for the last at least 4 or 5 years, I think. And this is probably the second or third time Jain Medical College is doing this case conference. And Dr. Vinayak has selected a patient probably of a unique nature in between an adult and a child whom we keep on seeing a lot, but we don't know what to do and how to go ahead with that. Dr. Dakshika, one of our residents, is going to present that. These are some of the very difficult kind of patients to deal and manage in the long term. Hope everyone will participate, give their own feedbacks and their experiences, so which can help all the people, especially postgraduate students, because most of the colleges don't have a dedicated child psychiatry department, child psychiatry and adolescent psychiatry department. And this will be a unique opportunity for most of the postgraduates in various medical colleges to have a glimpse of what and how it happens and how things require to be taken care of. And I request Dr. Dakshika to continue with her presentation. Dr. Vinayak, of course, will be there to lead and guide the case conference. I take this opportunity from my side to thank IPSKC for asking me to chair this session. Let's see how it goes. Over to Dakshika.
Good afternoon, everyone. Thank you, JNM Patil sir, for the introduction. I'll be sharing the PPT once. Yeah. Okay. So good afternoon, everyone. Am I audible? Right. So my topic today is psychosis in the young when genetics meets adversity. My moderator being Dr. Vinayak Koparde sir and chairperson being Dr. NM Patil sir. Patient profile, 14-year-old boy studying in 8th standard Kannada medium government school. Informants being grandmother and uncle. History reliable, however not reliable for perinatal and childhood history. History adequate. Socioeconomic status belonging to upper lower socioeconomic status according to modified Kuppiswamy scale. And with chief complaints of behavioral changes, muttering to self and sleep disturbances since 1 month, increased since 15 days, abrupt in onset and progressive in course. Family history, single born from a non-consanguous union, history suggestive of psychotic illness in late mother, and she would have suspiciousness towards family members, muttering to self. And she died 4 years ago when child was 10 years of age. Reason for death in mother was poor self-care and refusal to take medications and food. The family belongs to upper lower socioeconomic status, and there is history suggestive of alcohol dependence syndrome in late grandfather. No other significant medical or psychiatric illness in family members were found. Family life and relationships. Currently, patient lives with his maternal side grandmother. The expenses and daily food is taken care by the 65-year-old female via her pension of 1,000 rupees monthly. Grandmother is illiterate, laborer by occupation. She is overly critical and is over-involved towards the patient. Patient's parents separated after 2 years of marriage, and since then, patient on and off visits his father's place during his school holidays for approximately 15 to 20 days. Involvement of father is less and support is mainly by grandmother and uncle. Birth and developmental history. Normal vaginal full-term delivery and patient cried immediately after birth. According to grandmother, patient achieved all milestones grossly on time even though she didn't remember the exact years. Developmental course was typical and there were no delay in motor, cognitive, social, speech or language. There were no neurotic or externalizing traits reported by the attenders. Temperament was found to be easy. Activity levels were normal. Regularity, patient was regular. He would eat meals at time, sleep on time. Adaptability, patient was found to be adaptable, would easily adapt in new places and situations. Approach of withdrawal, it was positive. He would happily interact with new individuals who would come to house. Threshold of reaction normal and intensity of reaction was mild. Distractibility varied according to situations and quality of mood was found to be positive. Overall, easy temperament. Immunization, patient achieved till 5 years of age. Schooling history, patient studied in 8th standard and Kannada medium. Poor scholastic performance, 35 to 40%. However, details are not available. Good and cordial relations with friends and teachers, and interests were kabaddi. Past history nil significant and treatment history nil significant. History of presenting illness. The patient was functioning reportedly well until approximately 1 month ago, when his family began noticing a sudden and significant change in his behavior following a visit to a local temple. On returning home around 8 p.m., he had a tilak on his forehead and appeared calm initially, falling asleep soon after. However, over the next few hours, he repeatedly woke up and engaged in ritualistic bathing behaviors, particularly focusing on throwing water on his forehead. This cycle of sleeping and bathing was repeated 2 to 3 times that night. He also started expressing that he would become Ayyappa Swami, a deity worshipped in South India. From the following day onwards, he was observed to stare fixedly at specific locations in the house, particularly at a neighbor's house, without responding when questioned, and often became irritable. His overall social interaction decreased. He became withdrawn, in contrast to his previously outgoing nature. He was also noted to leave the house at night without informing anyone, often found at the temple, and would not explain his actions upon return. To prevent this, his family members began locking him in his room at night, after which he would cry inconsolably. In these days, he exhibited marked mood fluctuations, frequently alternating between aggression and prolonged episodes of unexplained crying. This crying would last up to 1 to 2 hours. He remained non communicative about these emotional outbursts. His school performance also deteriorated, with teachers reporting poor attention and prolonged staring episodes during class. Subsequently, he stopped attending school altogether. Family members also noticed him muttering and smiling to himself, as if responding to unseen stimuli. When confronted, he would appear startled and deny such behaviors. Attenders also reported patient would have disturbed sleep pattern. One day he would sleep the whole night, the very next day he wouldn't sleep at all. On asking him to sleep, he would lie down in his bed and after some time would be seen pacing around the house. Not only this, patient also noticed to have a reduced appetite over the past 15 days, initially skipping some meals and more recently refusing food entirely, except for tea as of the last 24 hours. Negative history. There was no history of fever or headache, no history of bilateral jerky movements of all 4 limbs, or no history of head injury, no history of vomiting, yellowish discoloration of eyes, pain in abdomen, no history of any substance use, no history of suspiciousness that people are trying to harm him or talking ill about him, no history of seeing things not seen by others, hearing things not heard by others, no history of excessive happiness, goal-directed increased physical activity, no history of low mood, decreased interest in daily activities and easy fatigability, no history of repetitive distressing thoughts, images or impulses, and no history of refusal to talk or maintaining a posture for a long time. Any questions till now? We can take up any questions for history of presenting illness and up till now.
Maybe, Dakshika, you can summarize if possible.
Yeah.
And then in the meantime, if there are any questions, we can hear from the students as well as anything pops up in the chat box. Yeah.
So it is a case of a 14-year-old boy and who is studying from Kannada medium, who had an abrupt onset of symptoms of behavioral changes, muttering to self, and sleep disturbances. And seeing the history, there is past history. There is no nil significant past history, but family history suggests of psychotic illness in the mother. Keeping that picture in mind, up till what HOPI is telling, it looks like it could be a vague psychotic spectrum disorder.
By now, you would have noticed that the order of presentation of history is a little different compared to when we take any typical adult psychiatry patient. So as Dr. Dakshika presented initially, the chief complaints, and then the focus is on understanding the child from a developmental perspective. So that's why starting with birth and developmental history, pregnancy, perinatal history, developmental milestones. Subsequently, you would also notice that there is history related to schooling, temperament, any positive medical history, and then history of presenting illness. This kind of a framework helps us to understand child's difficulties from a developmental perspective. And that is the difference I think students will appreciate when taking any child or adolescent presenting with behavioral concerns or any other difficulties. So if there are any questions, we can take. Yeah, Dr. Stuti has a question. So. Yeah.
Firstly, who is taking care of the child is temperament is easy. So his father is an alcoholic and mother is alcoholic, broken family. So who is taking care of the
Very good question. Actually, patient's parents had separated after 2 years of marriage. And since then, the maternal side grandmother is taking care of the patient. And history of alcohol is in grandfather, but father as such, he is not that much involved in patient's care. So mostly the maternal grandmother and the uncle takes care of the patient. Duration of illness is 1 month and increased since 15 days. Yeah. So history wise, as I told, like temperament wise, it was easy. So, and in school history also, even though he had poor scholastic performance, but no as such hyperactivity or any complaints from school that not sitting at one place, no such complaints were found as per the attenders. So the symptoms have started since 1 month only. In that, yeah, we found a bit restlessness and in ward behavior, a bit of hyperactivity, but just till 1 month.
Any other question? If there are no more questions, we can go ahead and continue the rest of the case presentation and take some more questions in there.
So moving forward, general and systemic examination. Height was found to be 152 centimeters, weight 26 kgs, and thin build. On plotting the anthropometric measurements on the WHO growth charts, patient's height was falling approximately at 25th to 30th percentile, while his weight was below the 3rd percentile, making him severely underweight. BP was found to be 124 by 70 mmHg. Pulse rate was 80 beats per minute and respiratory rate was 18 breaths per minute. There was no pallor, icterus, clubbing, cyanosis, or lymphadenopathy and edema. CNS examination, cranial nerves 1 to 12 were found to be intact. Motor, both upper limb and lower limb. Tone was found to be hypotonia in upper limb, whereas in lower limb, tone was normal. Rigidity was absent, and deep tendon reflexes were 2 positive, and power was found to be 4 by 5 on both upper limb and lower limb. Sensory examination, patient was anxious, hence detailed examination couldn't be done. However, would grossly respond to touch, pain, and pressure. Cardiovascular system, S1 and S2 heard, no murmurs were there. Respiratory system, normal vesicular breath sounds, no added sounds. GIT, per abdominally, no marks or lesions on inspection. Palpation, patient was guarded but non-tender. not cooperative for further evaluation. Mental status examination. Comfort. Patient was found to be fearful. Patient was uncooperative on repeated MSCs, would leave the room multiple times. He was seen scanning the environment throughout the interview. He would be seen making gestures at times of holding a fluid and grimacing. He would keep all his crayons and pillow beneath the mattress. On asking why he would do so, he wouldn't reply. He would repeat doctor's phrases when trying to communicate with him. At times was observed to repeat the word Ayappa. Rapport couldn't be established even on repeated trials. Social responsiveness, he wouldn't reciprocate on like smiling. Like if I would smile, he wouldn't reciprocate on smiling. Psychomotor activity was increased. Patient was alert. Attention and concentration wasn't cooperative and was distractible by slightest of the sound from outside the interview room. Speech, normal tone, tempo, decreased quantum. It was irrelevant at times but coherent. Thought, form, ecolalia was found. Patient would repeat interviewer's question. For example, if I asked, "What did you have in breakfast?" then he would repeat the same statement again and again. Stream, perseveration was found. On asking him how he was feeling, he reported he felt like a stone. On asking, did he take bath, he answered the same. And following this was followed for 2 to 3 questions. Content, delusional query, like it could be probably delusional percept, because after looking at his uncle's face, he would say that the uncle is making gestures of putting tilak on his forehead. However, in reality, no such thing was happening. Possession, no abnormality was detected. Perception, denied any hallucinations initially. However, throughout the interview, the patient was scanning the room. On repeated MSCs, he would report hearing a voice of God and seeing him. But on further questioning, he wouldn't respond. Child's version of the problem, according to the patient, he didn't have any illness except on and off dull aching headache. 3-wish test, was not in a state to comprehend and therefore didn't respond that much. Mood, said feels like a stone. Affect, was perplexed. Range was restricting towards fearful affect, and reactivity was absent. Lability was absent. Inappropriate to situation and incongruent to thought. Judgment was impaired, personal and social judgment, and didn't cooperate for test judgment. Insight was found to be grade 1. We'll go up on. Okay, we'll move forward for diagnostic formulation. 14-year-old male studying in 8th standard with family history suggestive of psychotic illness, in possibly schizophrenia in late mother, and alcohol dependence syndrome in late grandfather. Currently living with grandmother with high expressed emotions and lack of family support system. Presented with abrupt onset of symptoms characterized by behavioral changes, including over-religiosity, wandering episodes, withdrawn behavior, and school refusal, muttering to self, and sleep disturbances since 1 month, increased since 15 days. On MSC, scanning environment, grimacing, making gestures at times of holding a fluid, hiding crayons and pillow under the mattress, and repeating the phrase Ayappa. Psychomotor activity was found to be increased. In thought, form, echolalia was found, stream, perseveration, and content, delusional percept was found. Perception denies any hallucinations, affect, perplexed, and insight was grade 1. According to Rutter's multi-axial model, axis 1, early onset psychosis, probably acute transient psychotic disorder. Axis 2, query learning disorder, as he was having poor scholastic performance. However, no learning test could be applied because he was not cooperative. Axis 3 appears to be having average intelligence, and again, no test could be applied. And axis 4 is underweight. Axis 5, that is psychosocial stressors, had loss of mother due to psychosis at age 10, parental separation, critical and over-involved grandmother, poverty, pension-dependent family, social isolation, and not going to school. All these factors are the psychosocial stressors. Differential diagnosis. A child coming up at 14 years of age, we'll have to rule out organic causes. So Wilson's disease, anti-NMDA receptor encephalitis, thyroid disorder, evolving mood disorder, substance-induced psychosis, and autism spectrum disorder. Management. We had managed the patient by keeping inpatient as he was unmanageable at home and there was poor self-care and malnourished. Immediate goals, locus as told he was inpatient managed. Focus was to improve upon biological functions, irritability and restlessness, and to do a detailed evaluation with multiple resources. Modus was both pharmacotherapy and psychosocial intervention. Medication started. Patient was started on tablet risperidone 1 mg, 1 mg, half BD, which was increased to 2 mg HS, and later on tablet was shifted to syrup 1.5 ml BD, making it 3 mg. He was shifted to syrup as he was not compliant to medications. He would refuse taking medications, so we used to mix the syrup in food. Tablet clonazepam 0.5 mg BD and injection lorazepam SOS was kept 2 mg IM in case of agitation. Injection multivitamin IV BD was given as prescribed by pediatrician because of his underweight. And following all of these medications, we waited for 2 days. Even after that, patient was restless, due to which we added clonidine 100 microgram 1/4 TID. Investigations done along with pharmacotherapy, psychosocial interventions were also done. Investigations, blood reports, hemoglobin was found to be 13.7 and RFT, LFT, all were within normal limits. VDRL and HbSAg was negative. ECG was normal and CT brain findings were also normal. MRI, as a first line, we should have done MRI, but patient wasn't affordable. BPRS score before treatment was 50 and after treatment, after 1 week, decreased to 36. Family assessment, it was found that there was lack of support system and expressed emotions from grandmother. Psychometry tests, TAT and learning screening was not cooperative. Ophthalmology opinion was taken for Wilson's disease. No KF ring was found on slit lamp examination. Psychosocial interventions done. Psychoeducation and involvement of family members was done. Grandmother and uncle both were counseled in detail regarding the nature of the illness, need for medications and its side effects. Prognosis and need for compliance was explained. Involvement of father and uncle for adequate support was done, and they were counseled for the need to take adequate responsibility. Graded re-entry to the school was also done. Course in the hospital. Patient stayed for a total of 6 days in ward. Patient showed improvement in biological functions, irritability, and restlessness. There was some improvement observed in his fearful and scanning behavior, which was present on the day of admission and decreased on last day. However, his refusal to take medications properly still persisted on and off. Plan at discharge was to follow up after 2 weeks, assess for any side effects, and start school re-engagement slowly with 2 hours a day, building it up every day, the hours. Follow-up. Plan for follow-up was to assess for cognitive and other functions, deficits, and plan for cognitive remedial therapy. So, touching upon this topic talks about early onset psychosis. So, what is the developmental impact on the child thereupon if child develops psychosis? Firstly, there is disruption of brain maturation. This is a very critical period for during childhood and adolescence, especially for the areas like prefrontal cortex, which regulates executive functioning, working memory, social reasoning, and impulse control. Psychosis is associated with abnormal synaptic pruning, reduced gray matter volume, and dopaminergic dysregulation during this critical period. These changes interrupt normal trajectories of intellectual development, emotional regulation, and social maturity. Secondly, this affects scholastic performance. Because of delusions and hallucinations, it might interfere with perception and thinking. Disorganized thinking disrupts reading, writing, and comprehension. Negative symptoms like apathy and lack of motivation reduces classroom participation. Children may be misdiagnosed at this stage of having ADHD or learning disability due to overlapping symptoms. Long-term result is that most children with early onset psychosis do not return to age-appropriate academic performance even after symptom control. Social cognition, example, interpreting facial expressions, understanding sarcasm, theory of mind, is all impaired in early onset psychosis. This leads to social withdrawal, peer rejection, bullying or victimization, and failure to form identity and social roles. These impairments worsen isolation, reducing real life learning opportunities from peer interaction. Also, there are interactions with other neurodevelopmental disorders. Early onset psychosis frequently co-occurs with autism spectrum disorder, ADHD, and learning disabilities. All these comorbidities further complicate diagnosis and treatment and amplifies developmental delays. I would now like to take any questions.
Yeah, there are a few questions in the chat box which we can take. First of them being, what is the intellectual ability of the child?
Patient wasn't cooperative that much for any IQ assessment. We couldn't do VSMS also for the adaptive functioning. However, talking after taking the history wise, as reported by the grandmother and the uncle, he would take care of himself, do regular like eat on his own, buttoning, unbuttoning, all of that according to his age, regular adaptive functioning were fine. So even though he had poor scholastic performance, apart from that, no other deficits were found. So average intelligence mostly.
Yeah, I think that's an important question because any child who is presenting where the informant is not very reliable, you need to look into whether premorbidly the child had adequate intellectual capacities or not. But it appeared from the history that child was able to take care of himself, was able to handle transactions, would function independently, would travel to the school without much monitoring. And only during last 1 month, the difficulties had arisen. So it appeared that overall adaptive, conceptual, and other abilities fit into a kind of average intelligence in this child. Next question is, can you explain with example about perseveration in this case?
Yeah. Like I had told earlier, like I had asked, like, how are you feeling for mood assessment I had done. So he would say he feels like a stone. Thereafter, like when I asked him other questions like, did you take bath? What did you have for food? All these questions, he again and again repeated the same answer that he felt like a stone. Even after telling him that I am asking a different question, he would report the same answer. So perseveration is basically giving an answer beyond the point of relevance. And this was seen in this case. So according to me, it was perseveration.
Yeah, most likely it was impaired switching which child was having. And if you go in detail about types of perseveration, you can find different types of perseveration. And one of these is impaired switching, where the child or the person would repeatedly answer the same thing for a stimulus or a question and would have difficulty in switching. The next question is about, was any acute stressor identified for the patient's condition?
Good question. Actually, the father had remarried 1.5 months ago. And this could obviously impact the child. However, even after talking to him, he was not opening up that much, so I couldn't elicit that. But yeah, that could be a precipitating factor.
The other question is, was temporal lobe epilepsy ruled out?
Yeah, any seizure history was not there. I asked everything, but no EEG or anything we had gotten.
Yeah, I think that's again an important question where you want to know, are there any organic processes which are going on? And temporal lobe epilepsy is quite common in few episodes of seizures, and they can present with a lot of behavioral changes. Even though we try to take history related to behavioral arrests and sudden changes which occur in birth, the history was negative. Symptoms were more or less pervasive. Yeah, we wish we could do EEG to see underlying any temporal lobe discharges. However, the patient was not, family was not affordable, and with lot of system only we could do CT scan of the brain, which was normal. The next question is about attachment pattern. Do you think the child had a good, secure attachment pattern in this case? What are your thoughts? Because mother was ill and she died when he was 10 years age. It was mostly grandmother who was looking after the child. So, what do you think? It was secure or insecure?
It looked like more of insecure because there was no fixed. The parents who actually take care, one of them had illness, psychiatric illness, and after that, once they had separated, only the grandmother, who was aged and who was a laborer, was taking care. And from my grandmother's side also, like there was expressed emotions. So taking into picture, it was insecure.
Yeah. Attachment patterns again are quite important when one of the parent, especially mothers who are physically not available or emotionally or psychologically not available. In that case, the child may have underlying vulnerability, which may get triggered whenever they are faced with stressors and present with some of the psychotic episodes. So, I think we should always look into what kind of attachment child had the initial 2 to 3 years of age, and was there any kind of disruptions or insecurities or disorganized patterns which can help us to formulate developmentally as well. The other question is about parenting practice by the grandmother. Do you want to comment on that?
Throughout like parenting practice, there were expressed emotions again, like from grandmother's side, and there was over involvement, over criticality was there, and she didn't understand the nature of the illness. So we had to sit multiple times, multiple settings we had to take to tell her the nature of the illness, that psychiatric illness. Even though her daughter had an illness, still she wasn't accepting the fact that it is a psychiatric illness. So multiple settings were taken to counsel her.
Yes, I agree that grandmother herself had her own issues, health issues. She was frail, quite old, could not run behind this child who was showing a lot of behavioral issues recently. So she would end up having her own burnout and her own issues, which definitely could impact. And that is why it was important to address the family system and family issues as well in this case. When we talk about parenting styles, we also want to know the parenting was authoritarian, authoritative, or permissive. These are the three kind of parenting practices, and most likely the grandmother would fit into permissive kind of a parenting initially before the onset of illness. Yeah, so that helps us understand as to what else parents can do. Okay. The question is about psychosocial neglect could have resulted in stunting of growth in the child. What do you have? Do you have any comment?
Yeah, like obviously because there are multiple psychosocial stressors, not just one, and having a good parental support, care is very necessary for childhood development. So taking that into picture, and the fact that only the pension is being financial support for his care, um, psychosocial factors would definitely contribute for his stunted growth.
Yeah, many times we tend to look at only physical factors or nutritional factors which are important for growth, like what multivitamins, multiminerals, and taking adequate protein, calcium, and all. But many times, the impact of stress on the physical growth is highly neglected. And in that context, I think this is a very important question. The topic of the case itself is, adversity and genetics. So adversity do impact on the growth processes, hormonal release, growth hormones, normal adolescence, and that's why it's again important to look into those. Any more questions? Yeah.
you give us the prognostic factor in this side?
Yeah.
Because ultimately, this will only answer psychosis with a lot of psychosocial problems. How long we are going to treat this time? What are the common tips you are going to tell to the caretaker? That is most important. So
Yes.
ultimately, parents are caretakers are going to ask you these questions. Okay.
Yeah.
Can you please help?
So, yeah. Yeah. So, very good question. So, thank you for the very interesting question. And looking into the poor and good prognostic factors, like Sir said, early age onset is a poor prognostic factor. Gender being male is a poor prognostic factor. Family history of psychosis, mother having psychotic illness is a poor prognostic factor. Patient belonging to a poor socioeconomic background, having lack of insight, severely undernourished, and social isolation and academic deterioration. Need for caregiver supervision and lack of stable parental figures. All these and poor response to initial interactions and interviews, uncooperativeness. All these factors are poor prognostic factors. Good prognostic factors are very few in this case. So accordingly, I would like to counsel the family members that since it is a early onset psychotic illness, so long compliance is a very important factor. They should follow up regularly, and they should not keep him in any stressful situations. They should try to keep him in less stressful situations. Yeah.
I think other important things to help this family would be sharing of the responsibility. It's mainly the grandmother. Now, father who had neglected the child had to be involved. Uncle who was distancing himself and not taking. So the extended family were to bring in together. As Dr. Dakshika rightly said, adequate sleep, good nutrition would also play important role. Keeping child safe from, he has a lot of wandering behaviors. So some amount of monitoring is must in this child. However, compliance was an issue. So switching over to syrup formulation, I think that could be helped. When it comes to long-term management, we know that early onset psychosis, especially early onset schizophrenia, does not have a very good prognosis. So it would require a lot of support, bringing in families together and sharing the responsibilities. Not pressurizing the child for school, because we know that some deficits will be there, but how gradedly he can be engaged and slowly incorporated into a routine life will be essential. Even though there are a lot of therapies, psychosocial therapies, cognitive remediation, rehabilitation, and other things which would be recommended, looking into the psychosocial adversities and backgrounds, it will be difficult to comment those at this moment of time. However, on follow-up, it will be good to reassess cognitive functions, social cognitions, behavioral issues, and then reformulate the plan of management. So I think that was a very good presentation, Dr. Dakshika. I'll invite Dr. N.M. Patil, sir, for.
Dakshika, it was a good presentation, no doubt, but I have certain observations to make. Like, I am playing the devil's advocate here. Why it is not an affective disorder? He started with being religious, going to the temple, going out in night, not responding to anybody, being very stubborn, very this thing, and he has not exhibited any frank schizophrenic features. We agree that it is psychosis, but why not an affective disorder with an emerging affective disorder coming?
Like you said, like he had mood affective symptoms were there and increased physical activity was there. That is why we have kept one DD as emerging mood disorder it could be. However, like the increased physical activity wasn't goal directed, and the mood fluctuation was also not pervasive. Like there was no constant dysphoric mood or irritability or happiness, happy, euphoric. So that is why we have first kept psychosis, because the picture also like disorganized behavior was there. He would keep his crayons, pillow, everything below his mattress. He would do scanning and he was fearful on the day of admission also. Throughout the ward, he would scan throughout the interview that what is going on. So,
that happens in mania with the dysphoric symptoms. So we can't totally rule out. Psychosis, I agree. There is not a problem. Now there are, we can discuss this case, like he has adversities in childhood, where it could be genetic adversity because of his mother being ill, and whether his mother conceived during a time when she was on antipsychotics and when she had tried schizophrenia, and how much care she took antenatally. All these things are questions only. We don't have pure answers. And he definitely had in the formative years, first 3-4 years of life, he had more than his fair share of severe adversities. And this has happened during a time probably we think in terms of scientific proving to occur. So what and how much percentage they will be responsible is difficult to think. So the diagnosis is concerned, okay, it could be an affective disorder, it could be schizophrenia. We don't know, it could be anything. We'll have to wait and watch how it goes. Now, the management wise, like we have started with risperidone. My question to Dr. Vinayak would be, like, why risperidone? Why not anything else? What happens if he receives a more larger amount of, because he's 14, he's not all that bad. And if he receives, if he's not responding adequately, why not give him typical antipsychotics or something more substantial and see what happens?
With respect to early onset schizophrenia or early onset psychosis, the most evidence which is there for risperidone and aripiprazole, but aripiprazole practically we see that takes longer time of action and titration, not very well tolerated, especially when the child has a lot of behavioral symptoms. We need immediate cool down, and risperidone comes handy in helping that. Olanzapine is another medication which can, but olanzapine use of it in early onset psychosis, especially when they are adolescents. There are a good number of studies which show that there is increased risk of metabolic syndrome. So that comes as a little later option. Typicals not generally recommended unless you exhaust second generation antipsychotic options. Obviously, because of the risk of tardive dyskinesia and as we have better tolerable second generation antipsychotics, I think risperidone, olanzapine, and aripiprazole, these are 3 drugs, and only when we exhaust, maybe. But you would be surprised to know that many of these children who have early onset schizophrenia would end up having clozapine. So that's another fact we see. And we should be mindful that 1, 2, how many medicines we try and later on. Start thinking of clozapine early in the course, because that is something which can really help.
The next thing is, if the boy doesn't respond, what will happen to a course of ECTs? Could it be advised, like for example, if you wait for a month and if he continues to have severe disturbances, then would it be a second or third option, or is it totally ruled out? Legally, yes, it's not permissible, but with the help of MHRP, we can go ahead and take permission and think in terms of going ahead with ECT. So that is another thing. What is your take on that?
I agree, sir. Even though ECT is an option, but with the legal provisions, it has become the last option unless there is risk to the life, risk of harm to others, or serious suicidal tendencies or catatonia which is not improving. However, in this case, I feel that the child has started showing response. So, giving a good trial of antipsychotic medication should be helpful. Generally, in adolescents, the drug metabolism is quite faster. The liver is quite active, and that's why they may sometimes need as good a dose as adults, or sometimes more than adults, to help with their psychotic symptoms. So, giving a good trial, 2 trials, and I should be able to justify the MHRB as to why I'm giving ECT. So, good 2 trials of medication, and then subsequently persistent risky behaviors or risk of harm to self or others, or catatonia. I think those are the situations in which ECT I would like.
The next thing would be, Dakshika mentioned that the locus of treatment is in inpatient setup. He's a 14-year-old boy with a MHCA provisions, and we require to keep in mind that it's not very easy to admit him, especially his father is not there, his grandmother is there, and all sorts of complications. And even then, if still needed, we can always ask an MHRB to give permission to admit him. And the 2 other things which we should remember, like since it is a postgraduate case conference, is that within the next 3 days you will have to inform MHRB that you have admitted such and such. And he has to be admitted in a separate place, which not along with the adult patients. The third thing is, somebody adult has to accompany him 24 hours in the hospital as long as he is an inpatient, which are the legal provisions which are required to be taken care of. And as far as the overall prognosis is concerned, as we know that prognosis is poor, then at some point of time, maybe we'll have to think in terms of deploying injections, because this boy is very non-compliant, very non-cooperative also. These are the future issues that come. But these are difficult patients whom we will have to deal with. Maybe they pass from childhood adolescent to an adult psychiatrist who will become more, or I won't say less, he won't give so much importance to his age and the various other parameters, and he'll be treated like any other adult patient. And that transition becomes very difficult for the family and the patient, because it invariably works out like that. So there are many of these things. There's an eye-opener kind of thing. We keep on getting early onset psychosis. And as some questions were raised in the question box, chat box also, like we require to rule out organicity, possible, whether it be Wilson's or epilepsy or encephalitis or whatever it is. We require to find out if there are any precipitating factors. We require to establish a diagnosis of psychosis in the first place, and then decide whether it's possibly an affective psychosis or a schizophrenic psychosis. Depending on that, our prognostication will differ, and our overall treatment, long-term management will differ. And these are important things to remember. And this will give you an idea how psychiatry keeps on changing, and what medicines should not be used now may become an important medication alternatives when he crosses another 5 or 6 years. As Dr. Vinayak was telling, clozapine, he may end up with clozapine. Quite a few of them do end up with clozapine. And here we should remember that there are a lot of reports that clozapine is the first choice or very early choice of the treatment modality in psychosis probably gives better options and better prognosis rather than waiting until they become resistant and giving clozapine as a last resort kind of thing. So, yes, I think that brings us to an end of this case conference today. I congratulate Dakshika for doing a good job and Vinayak for choosing an excellent case for all of us to discuss and ponder about. And I thank IPS KC also for giving this opportunity to Jain Medical College to all of us to present this case. And I thank all the participants to put in questions in the chat box to have a very good active discussion about this case. Go to IPS KC, Dr. Narayan, you are there. Dr. Som, anybody is there? Suresh is there.
Yeah, Dr. Suresh.
Yeah.
Yeah. Yeah, on behalf of IPS KC, I would like to thank Department of Psychiatry, JNMC Belagavi for agreeing to host such a wonderful academic feast on this special occasion. So I would like to especially thank NM Patil sir, Vinayak Koparde and Dakshika Jain for her wonderful presentation and sir chairing the session and Vinayak being a moderator for the session. The whole session was really excellent and really fruitful for all the postgraduates. So one request from my side is like IPS KC has been conducting such a programs. So we request all the postgraduates to take actively part in such academic programs so that it will be more useful for you people. And on behalf of IPS KC, the CANCEPS 2025 is coming up. Kindly register for the CANCEPS and make the event grand success. Thank you once again.
Thank you.
Thank you, sir.